The overall objectives of the pre- and post-intervention assessments are to determine biomechanical and musculoskeletal factors contributing to the deformity and pain, to identify disease status and the extent of joint damage and involvement, to determine correct treatment strategy, to determine whether biomechanical management in the management of hindfoot pain will be effective or not. The objectives of history taking are to determine current medical status of the patient, such as demographics, history of disease control, history of past and present medications, history of concurrent medical conditions, cues that might influence treatment, occupation, because occupation is extremely important, and family and social history. During physical examination of the rheumatoid foot, it is of utmost importance to check and record any stiffness, tenderness, pain on motion, swelling, deformity, limitation of motion, extra-articular manifestations, rheumatoid nodules, since all these are signs of disease activity. Also, one should ask a few questions like, is the problem regionalized or generalized? Is it symmetric or asymmetric? Is it an acute, subacute, or chronic problem? Is it progressive? Do the symptoms suggest inflammation or damage to musculoskeletal structures? There are various outcome measures in rheumatology used to assess in an objective manner the disease activity and its effect on joints. These include some of these, the Ritchie Articular Index and the DAS-28, the Disease Activity Score 28 tender and swollen joint count. The Ritchie Articular Index is a widely used articular measurement for assessing joint pain and tenderness. This can be conducted by applying a constant pressure on the articulation being assessed. To ensure that no excessive force is placed on the joint, this is applied until there is blanching under the nail of the fingertip putting the pressure. This is scored by scoring a 0 if there is no tenderness, a 1 if the joint is tender, a 2 if the joint is tender and the patient winced, and a 3 if the joint is tender, the patient winced and withdrew. Basically, the higher the score, the more severe the problem. The DAS-28, the Disease Activity Score, is a combined index that was developed to measure the disease activity in patients with rheumatoid arthritis. It has been extensively validated for its use in clinical trials in combination with the EULAR response criteria, with EULAR being the European League Against Rheumatism. It is easy to use, which makes it also possible to collect valuable information about the disease activity of your patient in daily clinical practice. Evaluation of response to a treatment can make it much easier and more objective using the DAS-28. Just assess the number of swollen and tender joints and measure the ESR, the erythrocyte sedimentation rate. The DAS will provide you with a number between 0 and 10, indicating how active the rheumatoid arthritis is at that particular moment in time. Non-weight-bearing examination of the individual joints of the foot must be performed, and one must look out for range of motion or joint stiffness. Joint stiffness is increased resistance to movement of the joint. This is usually more pronounced following periods of inactivity or rest. The duration of early morning stiffness, severity, and the number of joints affected are known to be an objective measure of disease activity. One must be careful not to confuse joint stiffness with rigidity. When there is damage to the joint, rigidity will set in, which will be an important criteria when one is planning mechanical or orthotic therapy. Since deformity resulting from rigid joints cannot be corrected using these devices, quality of motion is also very important. Is there any crepitus as we move the joints? This possibly indicating that there is joint damage. Painful joints can be helpful in the assessment. Asking patients to describe the character of the pain is helpful in understanding the underlying cause. Presence of pain during specific activities can also provide usual clues. Also, one must look out for swollen joints because swelling is one of the cardinal signs of inflammation, and assessment of deformity. This assessment of deformity is of paramount importance since deformity in the feet will result in altered biomechanical function and thus possible musculoskeletal conditions and pain.
So this 66-year-old lady living with rheumatoid arthritis for the past 25 years is presently complaining of chronic lateral ankle pain. More or less, it is a constant type of pain which she feels upon walking. For all these kind of musculoskeletal foot complaints, it's very important to assess foot joint motion, and as we have said also, the quality of motion is very important. So when we start off, we need to look at the joints one by one, starting off at the ankle joint and keeping the foot more or less at neutral position. But in this case, there is a problem because there is quite a lot of rigidity at the subtalar joint. We need to apply a dorsiflexing pressure to the foot, but as can be seen, there is definitely a problem with ankle dorsiflexion, and equinus is surely one of the problems here. The subtalar joint can be assessed by grasping the calcaneus and trying to invert and divert. There is very little movement occurring here. This is quite rigid, so there is limitation of movement. The metatarsal joint can be examined by first the oblique axis, the dorsiflexing. This there is some movement, but not at all. And along the longitudinal axis, one can see that there is an adequate amount of motion. The first ray, there is also the at least 1 centimeter of motion. Also, the position, the neutral position of the first ray should be considered by looking at the tips of the fingers. Okay, and hallux dorsiflexion, there is quite good dorsiflexion of the hallux at the first metatarsalophalangeal joint. We can actually see the plantar fascia being tightened here. Doing Jack's test, however, there is no motion at all, which could indicate the possibility of functional hallux limitus. On the other foot, the picture is more or less the same. However, we have quite extensive hallux valgus, and we can see that the big toe is deviated. At least we don't have overlapping toes. This is quite a common manifestation in rheumatoid arthritis. Again, looking at the ankle joint, there is limitation of dorsiflexion, so there is ankle equinus. At the subtalar joint, there is quite a little bit more movement of inversion and diversion here. Also, the mid-tarsal joint oblique axis is very rigid, okay, and there is some motion around the longitudinal axis. There is hallux limitus, because the hallux, obviously because of the bunion here and the there is quite a palpable dorsal exostosis at the first metatarsophalageal joint, which is stopping dorsiflexion of the hallux. There is hallux limitus, which is actually made worse by applying the force on the first MPJ. Also, one can see that the hallux is medially, axially rotated. Very important, looking at the foot type, one can see that the forefoot is quite inverted relative to the calcaneus, even holding the foot at subtalar joint neutral position. And there is quite a difficulty in doing this kind of motion. However, one can clearly see that there is what one could possibly term forefoot varus. It is quite visible. It is quite extensive. Also, the other foot, forefoot varus, is also present, but at a lower extent than the left foot.